request the chairpersons to collect their certificates outside the hall near the selfie point. Thank you. So ladies and gentlemen, the next session, it will enlighten us about NRP update and peri-viable period, resuscitate or DNR. And it's with immense honor that I welcome the chairperson of the session, Dr. Alka Agarwal, consultant pediatrician in Lalitpur, UP, Dr. Ajay Gupta, medical director, Muskan Clinic, vice president, IAP, Delhi, Dr. Vikram Bedi, head neonatology level 3A, Bedi Hospital, Chandigarh, Dr. Farooq Ahmad Mir, professor and former head of unit, Department of Pediatrics, Government Medical College, Srinagar, Dr. Satish Sharma, medical director, Arcus Medi Center, New Delhi. A big round of applause for all the chairpersons of this session. Now, I welcome the speaker of the session, Dr. Somashekhar Nimbalkar. A big round of applause for him too. I request the chairpersons to kindly introduce the speaker of this session to our audience. Thank you.
Good morning. I introduced Dr. Somashekhar Nimbalkar, though he needs no introduction. He is MD and CPH Fellow of RGHUHS, and he is the Editor-in-Chief Journal of Neonatology, NNF, and Joint Secretary, KMC Foundation of India. He was the Chairperson 2023 IAP Medical Education Chapter and National Convener for the IAP NNF-NRP Program 2023. And he is the member of the International Pediatric Association. And he has many achievements and awards and papers to his name. So I request Dr. Somashekhar sir to please begin his presentation.
Thank you, sir. Thank you very much for the introduction, and I would like to thank Dr. Shaukat, Dr. Mushtaq, Dr. Ravi Sachin, and the rest of the organizers for giving me this opportunity to discuss this particular topic. It's supposed to be, I think, 20 minutes, but I guess 2 minutes for discussion, but I'll try and finish in about hopefully 15 minutes. I'll skip quite a lot of slides, so bear with me. So we were talking about NRP update, and second is do not resuscitate or resuscitation, whether to do for smaller babies in the peri-viable period. Now NRP updates happen every 5 years, while evidence keeps on gathering every year. The update kind of is done every 5 years on a regular basis. The update is initiated by an organization called as ILCOR. ILCOR is the International League for Research and Resuscitation, and as you can see in the slide, we have various associations across the world which are part of this particular organization. So we have the AHA, American Heart Association, the Asian Resuscitation Council, the European Resuscitation Council, and so on and so forth. So a lot of these councils get together, collect data, look at the evidence, and decide what is to be changed and what we need to change as far as our resuscitation practices are concerned. Do you find any country which is missing on this particular chart, which has the highest number of births in the world? So the country with the highest number of births in the world, which is India, is missing in this, so which is not a good thing. But last week, ILCOR allowed IRCF, which is the Indian Resuscitation Council Federation, into ILCOR. So next year or next time onwards, IRCF will be representing India in ILCOR. So we'll see how this goes. The algorithms, these are the algorithms of the AHA, American Heart Association. So when we talk about updates, updates can come from various areas. So generally, the IAP has been following the American Heart Association updates. The NNF has been following its own update, and in 2021, both IAP and NNF got together, and they have found they'll be releasing a textbook later this year, which involves the Indian update. So we'll have our own algorithm in the coming few months. So this is the AHA algorithm, which has not changed. So the update is that the algorithm did not change from 2015 to 2024. This is the European Resuscitation Council algorithm, which has also not changed much, but changed a little bit from 2015 to 2020. So despite the more evidence being available, little changes have happened, and while AHA and ARC are not the same update. So when I'm talking about updates, I'll be saying that AHA had this update, ERC has this update. The NLS or the update followed by the United Kingdom is also slightly different even from the European Resuscitation Council. So updates, when we talk about what we need to do, we need to be aware that different countries might be following different steps during the resuscitation algorithms. There is a mild deviation at various points. So we'll discuss a few of that as we come through. So things are going to be different. So the European Resuscitation Council actually tells you whether the baby has transitioned normally from the in utero environment to the ex utero environment. So satisfactory transaction is something that we have tone, heart rate is more than 100. If the heart rate is less than 100, then you have what is called as the incomplete transition, and a failed transition is when your heart rate of less than 60 when the baby starts. So they have diagrams which tell you whether the transition is good or poor. Okay, so there are various concepts which have been reaffirmed in the previous. I will not go into this, but these are which have not changed. So there are a few slides which say that that stuff which has not changed. A few things on the pre-birth question. So before a baby is kind of, you attend to the resuscitation, you ask various questions to the obstetrician. And so one question basically has changed. There has been more focus on what is called as the umbilical cord management plan. So how are you going to manage the umbilical cord? There was a brief discussion when Amit said that umbilical cord should be clamped at about 1 minute. That is also the Indian recommendation. While ECOG did not address umbilical cord management very clearly, AHA said that we should cut the cord at 30 seconds. The Indian government says 60 seconds. ARC says 60 seconds. And so in general, what we should be following, we should cut the cord at 1 minute of after delivery. So this is for normal babies for making a normal transition. And so, but in an incomplete transition or when the baby is not breathing, there is a clear-cut recommendation that we should be cutting the cord immediately. So if the baby is not breathing very well and has difficulties breathing, then maybe the cord should be cut immediately. So when we are in a state where we are cutting the cord immediately, we can try and do umbilical cord milking for preterm newborns for more than 28 weeks of gestation. For less than 28 weeks of gestation, umbilical cord milking should not be done. So this is a very specific guideline. For temperature environment, there are various strategies. So basically, one of the most important factors which is not generally paid attention is the temperature of the delivery room, which in the AHA says should be between 23 to 25 degrees centigrade, while the ERC has very specific recommendations for temperature. It says that the baby is less than 28 weeks of gestation which is getting delivered, then the delivery room temperature should be more than 25, and for other babies it should be between 23 to 25. The AHA does not make any specific recommendations for skin-to-skin care. It says that every baby who is born normally has a normal transition should get skin-to-skin care at birth, should be placed in the mother's abdomen. The ERC, the European Council, has specific recommendations where it talks about babies between 28 to 32 weeks of gestation had a lower blood temperature when they received skin-to-skin care. So they caution for babies who are below 32 weeks of gestation. So anybody more than 32 weeks of gestation after delivery can be kept on skin-to-skin care immediately at birth itself. Okay, if you had looked at the new book of the AHA book, it has a different order, and this is often a question. In the earlier update, there was stimulate used to come last, and here stimulate comes earlier. And this is just because there is no evidence behind this change of practice. This is just because what everyone does on a regular basis. Assessment of heart rate. There has been a lot of importance of heart rate assessment because heart rate assessment tells you how the baby is responding to your steps that you are taking. So in 2015, AHA changed heart rate assessment from this auscultation to saturation monitor to actually doing ECG monitoring. Unlike AHA, ERC and even the UK councils have not recommended EEG. The IIT NNF also have not recommended ECG. The main reason being because it is not going to be widely available. So we still believe that, and if you look at the ERC recommendation, it is saying to use stethoscope and saturation monitor with or without ECG. So ventilatory support of the birth. Now, in the 2015 recommendation, UK specifically had what I called as 5 initial breaths, where they gave a pressure for a longer period higher pressure before they started ventilating babies, which was stopped after the sail trial. And hence, the AHA recommendation is that you can use a slightly longer inspiratory time for the first few breaths for both term and preterm newborn, while ERC specifically recommends using 5 initial inspirations of 2 to 3 second duration. Well, in 2015, UK had said 5 second duration, and some people have said that now there is a strong recommendation against 10 seconds of what are called as sustained inspirations. So these have been kind of abandoned, which was not adopted by most of the countries except for UK, and UK abandoned it in 2020. These are some things which we need to understand has kind of changed. The rate of ventilation, it goes from 30 to 60 or 40 to 60 based upon what body is recommending it. So AHA says 40 to 60, while ILCOR says around 30 to 60. The pressures also have varied. What pressure should be used for both term and preterm? AHA does not recommend any specific pressure. It says around 20 to 25 centimeters of water, while ERC is very specific about pressures and rates. The European Research Council says about 30 per minute, and initial PIP of 30 centimeters for term newborns and PIP of 25 centimeters for preterm newborns. And while previously people used to use 20 centimeters of water, that is not sufficient. And also ERC specifically recommends a 2% technique for ventilation, so that one person is holding the mask and the other person is pressing the back. So this is very specific. In the UK algorithm, which has been released in 2021, they have very more specific. They don't even prefer. They prefer using the laryngeal mask airway as opposed to the mask itself. So they have gone further and started stressing upon using of NMA, which we most of us don't currently use. For oxygen administration, AHA did not specify anything. It generally said that for babies who are preterm, don't start with just oxygen, room air, you start with a higher concentration of oxygen. But the ERC has very specific recommendations. For more than 32 weeks room air, 28 to 31 weeks, 21 to 30%, and less than 28 weeks, 30%. So these are ERC recommendations for using oxygen for preterm babies. And so for newborn babies who are less than 32 weeks of gestation, a saturation of 80% and or heart rate of less than 100 minutes at 5 minutes of age should be avoided, because anything in contravention to this increases neonatal mortality. Medication, most of us know that we used to have this earlier recommendation of 0.01 to 0.03 milligram per kg. The first dose, initial dose is changed to 0.02 milligram per kg. So this has changed, and also the flush volume has kind of changed. So this has increased, the flush volume has increased. These are differences between AHA and ERC. I will kind of skip that. We will talk about this in detail, but generally when you want to withhold, when you want to stop resuscitation of a newborn baby, the recommendation is after 20 minutes after birth, if the baby is still not breathing, you would want to stop resuscitation. In the earlier recommendation in 2015, it was at 10 minutes of asystole after doing complete resuscitation, you would stop resuscitation. This was kind of clear-cut recommendation for stopping resuscitation. Now, in the new guideline, and also in the book, it does not specify that after doing all kind of efforts that you stop recommendation, but the general understanding is this is 20 minutes after you have done proper resuscitation and everything has been done properly, and you continue doing this properly for 20 minutes, then you can stop resuscitation, not 20 minutes after birth per se. So that's the interpretation slightly varies, and this is something which, but they have increased it from 10 to 20 minutes specifically because they found that many babies who were resuscitated beyond 10 minutes or beyond 10 minutes of resuscitation actually had better outcomes. Okay, so this is your AHA algorithm. This is the ERC algorithm which I have been discussing for the last few minutes. There are a few slides, but I will skip these slides. This basically pinpoint the differences between the two this. Coming to the second part of the lecture, which is the lecture by itself, and I'll try and finish in 6 minutes. This is called as the periviable period, or what should be done to babies who are small and whether they should be resuscitated or not. The earlier discussion of whether babies should be resuscitated and how long they should be resuscitated for normal babies or babies of preterm, and who got resuscitated and when to stop resuscitation. This is a completely different discussion. This is talking whether we should resuscitate or we should start resuscitation of babies who are small or in the periviable period. Here we go. So recently we are publishing Journal of Neonatology. This will come in the September issue. Whether babies in the periviral period should be resuscitated or not. There are two views. One says to resuscitate, one says to not resuscitate. Both these views are presented in this particular article, and I can share the article in the conference groups later on. And so this is, if you look at this article, you'll get an idea of what I'm going to be talking about. So periviral period is between 20 weeks to around 25 weeks to 6 days. This is what is generally considered as the periviral period. This is the international definition. What we feel that maybe for India we should kind of have a separate definition for it rather than sticking to this because it makes things much more difficult for us. Okay, and so this is just a chart to let everyone know what would generally be considered as premature, early premature. There is a term called as early term being used now and full term. So these are various definitions which are there, which we should kind of be aware of when we are discussing this particular topic. Okay. There are various long-term medical and social consequences of preterm birth. So when a baby is born preterm, people have followed them up till old age. And one of these articles said that babies, people who are born between 1967 and 1983, so this is like many years back, these people would be at least around 60 years old now. The risk of medical and social disabilities in adulthood increases with decreasing gestational age. So generally it means that if you are born preterm, you are kind of marked for life and you can have issues later on in life also. So that is something we should consider. So we all know about cerebral palsy, how it increases with decreasing gestational age. You can see the percentage increase in decreasing gestational age, mental retardation. So we have to consider all this when we are talking about whether to resuscitate a baby in the periviral period. So there are these other things in autism, psychological behaviors and other major disabilities which also take part. So this is a general list of what can happen if you are born preterm. Okay. I will skip this slide, but generally this says that it is difficult to determine gestational age in the peripheral areas, especially and that when we talk about periviral period, if you are not able